You can just start talking. They'll shut up.
Good morning. Miguel Diaz, one of the second year EM residents. I just wanted to take the chance to thank the social ethical part of the care team, as well as Dr. Diaz and Dr. Dream. We're talking about incarceration and mental illness.
Click on.
Just a brief outline, introduction about incarceration rates in the country over the last 50 years or so. Current trends, looking at demographics, who's being mostly affected with incarceration, looking at some of the issues with healthcare of incarcerated individuals, and then focusing on mental illness, and then looking at interventions and resources, and trying to focus here in New York City. So from 1978 to 2016, there was a nearly five-fold increase in the amount of people that are incarcerated. Every year, about 10 million people pass through the correctional system. In 2016, the U.S. Correction system had approximately 6.6 million people under its supervision. About 4.7 million were under community supervision, being probation and parole. Unfortunately, the people in community corrections are the largest population in the justice system. They don't have the constitutional mandate for health care that people who are incarcerated have. Looking at rates across the world, as usual, the U.S. is number one. Has the highest rate of incarceration of any country in the world. Really started in the 60s and 70s. President Nixon and the war on drugs. Further additions by Reagan and Bush Sr. Specifically, the Sentencing Reform Act of 1984 established mandatory guidelines for judges, sentencing guidelines, limiting their discretion during sentencing. It abolished federal parole, individuals in federal prisons having to serve 85% of their sentences. The Anti-Drug Abuse Act of 1986 enacted new mandatory minimum sentences for drug possession and distribution. And in the mid-90s, numerous states passed three strikes legislation, where after 3 arrests, there was a possibility of people getting sentenced to life in jail. There was also guidelines for sentencing, like crack cocaine versus powder cocaine, which were about 100 to 1 in the amount of time someone was sentenced to. Looking at incarceration for drug offenses, 1980 compared to 2018, you can see how much it's risen, state prisons, jails, and federal prisons. Unfortunately, getting arrested for drug possession or distribution is affecting people of color, even though rates of use and sale are about equal between whites and blacks, about 7%. Respectively, and around 2000, whites composed 72% of illicit drug users compared to the 15% share contributed by blacks. Over on the right, you can see who's getting arrested and who's getting incarcerated for this. Another graphic just showing the demographics, comparing the prison population to the U.S. population. Among men ages 18 to 64, 1 in 87 white men are incarcerated, have been incarcerated, 1 in 36 Hispanic men, and 1 in 12 black men. By middle age, black men in the U.S. are more likely to have spent time in prison than to have graduated from college or joined the military, and far more likely to be sent to prison for drug offenses. For women, lifetime likelihood is 1 in about 110. For white women, 1 in 45. For Hispanic women, and 1 in 18 for black women. Looking at the kind of like the rates of different conditions across the board, inmates in federal, state prisons, and jail are unhealthy compared to the general population, for chronic conditions, for HIV, and for psychiatric conditions as well, major depression, mania, and psychotic disorders. Basic care for people that are incarcerated has basically been obtained via Supreme Court decisions. 1976, Estelle versus Gamble found that deliberate indifference to serious medical needs constitutes a violation of the Eighth Amendment, prohibition of cruel and unusual punishment that led to the expanded healthcare services. And then in 2011, Brown versus Plata ordered California to reduce overcrowding in prisons because of the associated failure to provide adequate healthcare to all inmates. And here, looking at psychiatric conditions as well as alcohol, substance abuse, it's estimated that greater than 65% of incarcerated individuals meet criteria for alcohol or other drug dependence. Only about 11% receive drug treatment while incarcerated, having higher rates of withdrawal while in custody and overdose when they return to the community. About 18 to 30% for male inmates compared to 14 to 16 in the general population for alcohol dependence, and 10 to 48 for substance use compared to 4 to 6 in the general population. And then looking at solitary confinement, there's a case of Khalif Browder. 2010, he was accused of stealing a backpack, falsely accused. He remained at Rikers for 3 years, refusing to plead guilty for a crime he didn't commit. Spent about 2 years in solitary confinement, was also beaten, mistreated by both guards and inmates, eventually released, and charges were dropped. Suffered from depression. Some time after being released, committed suicide. And looking at suicide rates in jails, it's a leading cause of death in local jails every year from 2000 to 2016, accounting for more than 1/3 of all deaths. And then looking at the suicide rates in jails, state prisons, compared to the rates in the U.S. Solitary confinement increases the risk of premature death after release, and multiple placements further increase that risk. Systematic review found that solitary confinement was associated with an increase in adverse psychological effects, self-harm, and mortality, especially by suicide. Smaller effect noted for mood, psychotic, and hostility symptoms. And these effects are beyond the effects of general incarceration or the presence of prior mental illness. Taking a look at mortality after release, there's a 12-fold increase in all-cause mortality in the first 2 weeks after individuals are released from prison. Higher risk of death, the leading causes are drug overdose, cardiovascular disease, homicide, and suicide. One study reported that approximately 1 in 12 individuals is hospitalized for an acute condition within 90 days of release from correctional facilities. In the first 2 weeks after release, former inmates are 120 times more likely to die from a drug overdose than members of the general public. This is a study in California looking at ED visits, comparing individuals with and without criminal justice contact. Those with criminal justice contact had a higher prevalence of being frequent ED users, 27% compared to 9%. A higher risk of an ED visit resulting in hospitalization, 26% compared to 15%. And a higher prevalence of mental health conditions, 52 to 39%. Of the top 10 primary diagnoses for those with criminal justice contact, 4 were behavioral health conditions. And for those that had no contact with the justice system, they weren't in the top 10. Focusing more on mental illness, de-institutionalization of the mentally ill in the last 50 years and punishment for drug users starting in the 1970s shifted the burden of care for addiction and mental illness to jails and prisons. The largest facilities housing psychiatric patients in the U.S. are not hospitals but jails. More than half of inmates have symptoms of a psych disorder, with major depression and psychotic disorders being 4 to 8 times more prevalent than in the general population. But only 22% to 7% of jail inmates receive mental health treatment. In 1955, there was about 550,000 patients cared in state psych facilities. Today, there's less than 50,000. And focusing here in New York, there's increased spending on mental health shelters, decreased spending on inpatient beds. There's been an increase in the mostly disturbed persons calls to NYPD, and more seriously mentally ill individuals in New York City jails than in state psychiatric centers. The trend has been to divert funding from 24-hour structured care to community treatment, but there's a part of the individuals that require 24-hour care that it's just not safe to be in the community. These individuals cycle between homelessness, incarceration, and the emergency department. There was a study looking at individuals that were frequently incarcerated at Rikers Island. Looked at 800 individuals, compared them to a control group of 800 that were incarcerated. What they found was in a 6-year period, those that were most frequently incarcerated had about 23 incarcerations and stayed in jail for about 28 days. It cost the city about $130 million to lock these people up and provide care for them. Generally, these individuals were older, more likely to be non-Hispanic Black, diagnosed as seriously mentally ill, homeless, and having a history of significant alcohol or substance use, mostly arrested for misdemeanors, low-level theft, possession of small quantities of drugs, trespassing, or fare evasion. I wanted to focus on some of the interventions that have been developed to try to help these individuals, improving psychiatric care in correctional settings, improving access to substance abuse treatment, and mental health services. There's also mobile police emergency teams consisting of specially trained law enforcement, and sometimes they're accompanied by mental health professionals. Most law enforcement are not used to dealing with individuals with psychiatric disorders, are not used to their behavior, and probably find it easier just to incarcerate these individuals. There's also mental health courts. They hear cases of individuals with mental illness who are charged with crimes. They work with mental health professionals to devise and implement treatment, including medications, therapy, housing, and social rehabilitation. And then there's a re-entry process that begins prior to release from prison, trying to set these individuals to succeed in the community. Looking at some of the interventions developed here in New York City, there's a program for accelerating clinical effectiveness, PACE units that have been instilled in New York City jails since 2016, improving therapeutic environments for these patients. They have staff available 16 hours a day, really trying to focus on individual therapy, medication management, comprehensive social work, and reentry. Looking at the clinical outcomes for these patients in these units, there was a 50% increase in medication adherence, 25% reduction in both self-injury and injury sustained in fights, and 85% reduction in 30-day rehospitalization rates. Looking at H&A specifically, they took over mental health services in 2016 from a private vendor. Some of the programs they have are EPAS, enhanced pre-arrangement screening services, forensic psychiatric evaluation court clinics, and they have basically 4 levels of mental health care available in the jail system. They have first the equivalent of an outpatient clinic in each jail for patients with serious mental illness. They have 18 mental observation units, or about 540 beds. For individuals that require a little bit more care, they have the PACE units that I mentioned previously, about 150 beds in the city. And lastly, there are dedicated inpatient psychiatric beds at Bellevue for men and Elmhurst for women. Another program that we actually have at King's is the PORT program, Point of Reentry and Transition Program. It's led by Dr. Dreamer here. Another intervention is this law enforcement training. This study was based in Georgia, looked at 6 suburban or urban police departments with their officers from 12 to 40% of them having trained to deal with individuals with mental illness. In this study, CIT trained officers were significantly more likely to report verbal engagement or negotiation as the highest level of force used. And for the trained officers, referral to transport was a more likely outcome than arrest. Mental health courts, another intervention that's been found to have a reduction in risk of violence and recidivism. At the time that this article was published in 2015, there were about 400 mental health courts in the U.S., but research is lacking. All these interventions are being done without further research to really identify the ones that are most effective and most cost effective as well. I reached out to Dr. Dreamer to ask him about some of the resources available here in New York. The Fortune Society and the Osborne Association, based here in New York, provide services to people with incarceration history. The Transitions Clinic Network is a national organization and the leader of post-incarceration care. This is the Port Clinic. Dr. Dreamer was mentioning that most patients he sees in the practice have some sort of mental illness. On several occasions, he's been asked to administer long-acting antipsychotic medications because these patients leave jail with a prescription but nowhere to get the medication. The program acts kind of like a safety net for them. And I know it's difficult to identify these individuals in the ED unless they provide a history of incarceration and just tell you about it. But I guess some of the cases that we see that are in custody, it might be useful to print out some of these flyers for them and provide it for them in their discharge paperwork. My references. Any questions?
It's a really difficult problem. I've worked in jails in the past. I worked in even with juvenile and the juvenile detention center Stockford in the Bronx in the past. It can be very difficult and challenging. There's a lot of anger there. There's a lot of need there. And unfortunately, it just seems from the time I worked there, it seems to have gotten worse, not better.
Yeah, I mean,
Unfortunately.
it's interesting that they're implementing like those clinics and like the psychiatric and mental health like opportunities within the jail. Have you noticed any, like, have they published anything in terms of like when they come out of jail, their rates of depression and suicide after this implementation, or is it just too early?
I think it's still too early.
Okay.
It's difficult to find research about it.
Okay. And that Port Clinic, if you can go back to that slide. So this is something we can basically just hand out to the last one that you had with the Port information.
Yeah.
Okay. This is for just HHC system, right? Okay. Cool.
The Bellevue and the Kingstown.
Yeah. I'm really glad that you brought this up. That's like a great thing that we can give to our patients.
If we can get this on Clinical Monster, I think that'll be out there.
Yeah.
I mean, this is a real problem. I mean, especially the mental health. There's so many people who go to jail just for having mental health issues, and nobody cares. I mean, people care, we care, but I'm saying the system doesn't really care. And this is something that really helps these patients. Because a lot of times we don't even look at the numbers of all the patients who get sent back to jail because they're violating parole. They can't really they don't have the insight into the decisions that they're making that's getting them back into jail. And they just drag back to jail. They don't really understand anything that happens. It's really terrible.
And if I remember, you can really refer anybody to this clinic if they ever had a history of incarceration. It doesn't have to be someone who just was, released recently. So when in doubt, just refer. Like Diaz was saying, it's tough to identify these patients sometimes. But
Yeah.
Sometimes you talk to patients that are there for med refills or something, say, oh yeah, I was in jail and I just got out here a year ago. I haven't seen doctors. That's like the perfect patient that we can introduce to this. Someone especially who's been out for a long time and hasn't been reintroduced to medical care and maybe struggling in other areas that we haven't investigated ourselves during.
Yeah, we probably don't ask enough. The same way we have to maybe change our focus on asking people about food insecurity so we can give them a box, identifying these patients, why aren't you taking your medications? A lot of times it's like, oh, well, I was getting all my medication in jail, but I got out 6 months ago and I haven't seen the doctor since. And so, where their HIV or whatever, or their diabetes is well controlled while they're in jail, getting your medication. They didn't have the resources afterwards, didn't really know how to go about things. So, yeah.
I have an administration. So I guess if I type in the word report, is that like a consult that pops up? Like if I want to establish follow-up, if that's over in e-building?
No, I just put in Dr. Dreamer.
Yeah, our building.
Yeah, and if the slide before this is like the hotline and things like that too. So I don't think there's a real official referral. It's more you can give them the number to call and we can refer just in general to go to your see Dr. Dreamer. But otherwise, you can give them this phone number and they call. And if your counselor is there, we'll help set it up and make sure they don't call.
It's on Clinical Monster already. MJ put it up. She's been really amazing at that. Look under social service and housing under all patients.
And this is to provide them with mental health only, or do they also send them to primary care?
I think it's primary care as well.
I guess addiction too.
They'll do actually all of this. Addiction included. Dr. Dreamer is addiction medicine. They can do buprenorphine if they were on that in Rikers. They also have peer counselors who are people who themselves were formerly incarcerated and can actually help them navigate the system.
Yeah, and they help with a lot of the social aspects too, right? So it's not just for medical care. It's like a very big comprehensive clinic. So they can do a lot of the things that we would normally call social work to really help for, but this is a clinic that's geared towards this patient population to help them specifically.
All right, thank you, Miguel. Really great topic.